Mrs. Sanchez, you're recognized.
Thank you, Mr. Chairman, for holding this hearing, and I want to thank our witnesses for being here today. Post-acute care is a critical part of the care continuum, but it's often fragmented in its delivery, so I'm encouraged to hear the witnesses' ideas to help address some of these issues. Something that I personally care deeply about is long-term care. More often than not, caregiving is unpaid and it's provided by loved ones. 2/3 of caregivers in the United States are women. And I've worked for over 10 years to pass a caregiving tax credit, and today my colleague, Mr. Carey, and I reintroduced the Bipartisan Credit for Caring Act. I hope that we can pass this on a bipartisan basis to provide much needed relief for working families, because the only other way working families can afford long-term care is through Medicaid. And Republicans are hell-bent on pursuing an $880 billion cut in Medicaid to pay for the tax cuts for the largest corporations and highest income earners in the United States. The fact is that 3 out of every 5 nursing home residents rely on Medicaid. Mr. Carlson, I want to thank you for your testimony on long-term care and your notes on staffing standards in skilled nursing facilities. I want to ask you, and if you could answer briefly, because I've got a lot of territory to cover, what kind of impact would Medicaid cuts have on access to nursing facility care?
Thank you for the question that has been mentioned. Nursing facility residents, you're talking about close to 2/3 of residents who are reimbursed by Medicaid. And so that's just obviously a tremendously big piece of reimbursement for nursing facilities. So any dramatic cuts to Medicaid funding, as I mentioned earlier, the consequences fall to the states. They don't have enough money to do what they want to do. What needs to be done to cover the health care needs of older.
So the individuals would be responsible. Can many of them afford that?
Yeah, I mean,
on
then it falls on the facilities aren't adequately reimbursed, or the eligibility standards are changed. One way or another, it becomes untenable for everyone. The providers, it's likely to become untenable.
But I'm focused on the patient. What happens to the patient?
For the beneficiaries, they either don't have coverage, or the financial standards would be such that they couldn't afford to
and so they wouldn't
the
get
care
the
that they needed.
They wouldn't get the care.
Yeah, you get squeezed out.
They wouldn't get the care. They'd be squeezed out. And what would that do to the nursing home industry in states like Alaska, Georgia, Louisiana, or West Virginia?
Those are states with an even higher percentage of Medicaid benefit. I think north of 70%.
So $880 billion cut in Medicaid would mean that those facilities and their patients who are no longer receiving the subsidies, what happens to those facilities?
The impact is even bigger in those states because the percentage hit on nursing facilities is that much higher. There's not enough money for individuals. There's not enough money for providers.
Okay. Thank you. I want everyone to recall when my Republican colleagues on this committee voted to rescind the minimum staffing rule for nursing facilities last year. Our own chairman said in his opening statement during our markup last year, quote, "Without access to more staff, nursing homes, particularly those in rural areas, will have no choice but to reduce the number of residents they admit or shut down altogether." Let me repeat that. Without access to more staff, nursing homes will shut down. So let me ask, are Republicans still outraged about rural nursing facility closures? Because an $880 billion cut in Medicaid will close many of those rural facilities. So I urge you to stand up to oppose those cuts, which will devastate those rural facilities and the patients that they serve. I also want to talk about access to issues in post-acute care. This is an issue that I've worked on a bipartisan basis with Ms. Van Dyne of this committee, and I'd like to submit for the record our letter on MA network adequacy standards, which still do not include IRFs.
So ordered.
Thank you, Mr. Chairman. I also consistently hear that patients experience long delays in post-acute care due to Medicare Advantage's plan's prior authorization practices. Mr. Tongeli, in your testimony, you cite improper denials in coverage for more intensive post-acute care. What causes delays in care when a patient transitions to the post-acute setting at an IRF?
Thank you for the question. The delays result from the process that has been set up by the Medicare Advantage plan. Like I said previously, fee-for-service Medicare patients, we can assess that patient and bring them in within 1 day. If it's a patient who has Medicare Advantage, we have to take that clinical information, we have to provide it to the Medicare Advantage plan for approval to bring the patient in. Often what we see is an immediate denial.
And how often are those prior authorization claims denials appealed and overturned?
They're appealed and overturned?
Yes.
Overturned. What we find in our experience is that roughly maybe 40% of the ones that are initially denied can be overturned during appeal.
Thank you, and I yield back.